Okay, so starting with dermatology, first I will take up the infections, superficial deep infections, okay, and then various reactions like urticaria or drug reactions, okay, then dermatitis. So this way I will go. So starting with toxic shock syndrome, very important topic, very high yield, toxic shock syndrome. So this is a picture of toxic shock syndrome. So mainly it occurs, as we know, generally due to retained tampons, or like the patient has posterior epistaxis, then and we go for dressings. So we put a dressing inside. So that causes release of exotoxins, or there is a localized staph aureus infection, okay, anywhere in the body. Suppose the patient has some sore throat, so because of staph aureus, and that caused, our patient has pneumonia, so that caused exotoxin liberation. So because of this exotoxin, we have toxic shock syndrome. So it may be staph aureus, or it can be streptococcus also, okay. So this staph aureus, it causes liberation of exotoxin, which acts as a super antigen. So this is the mechanism, the tampon, and this is the tampon, and you can see the liberation of exotoxins, okay. And this further damages various means it causes various manifestations, okay. So generally when an antigen comes to the enters the body, like this is a, when antigen present enters the body, so there is a processing of the antigen by antigen presenting cells, okay. And this is the supposed antigen presenting cell, okay, as you can see. And this will cause, like the patient, like there can be macrophage, or there can be another thing, okay. So these are antigen presenting cells, okay. So they will present the antigen to the T cell, and these, there will be activation of these T cells, and they will liberate various uh, interleukins, okay, as you can see, and that will cause clinical symptoms. But here, in case of toxic shock syndrome, there is production of exotoxin. So this exotoxin will cause direct activation of this T cell. So this is called, that's why they are called super antigen, because they cause activation of the T cells directly without any processing. There is no involvement of these antigen presenting cells, okay. So there is direct activation of the T cells. So that's why they are called super antigen, okay. And we have diagnostic criteria of toxic shock syndrome. So as it is a, there is shock, so the patient will have temperature more than 100 to 102 degree Fahrenheit, okay. So because there is a liberation, because there is staph aureus infection, so there is a temperature will be high, and as the patient is in shock, so systolic blood pressure will be less than 90, okay. Systolic blood pressure will be less than 90, and also the patient has diffuse maculopapular rash with desquamation on the palms and the soles, okay. So there is diffuse maculopapular rash with involvement of palms and soles, okay. And so this palms and soles, as I said earlier, also it occurs in toxic shock syndrome in case of secondary syphilis, in Coxsackie A virus, in Rocky Mountain spotted fever, and also Keratoderma blennorrhagicum, which is reactive arthritis, okay. So involvement of, also there is involvement of 3 or more organ systems, okay. So that makes characteristic of toxic shock syndrome, okay. So the patient may have involvement of GI, that is nausea, vomiting, diarrhea; renal involvement causing high burn creatinine; liver involvement causing raised AST, ALT, okay. Blood involvement causing thrombocytopenia; there can be involvement of the mucous membranes, like vagina, pharynx, and conjunctiva causing conjunctivitis. And also the patient will have muscular damage. So whenever there is muscular damage, it will cause high CPK. So in toxic shock syndrome also there is high CPK if there is damage to the muscles. And the patient's involvement of the CNS causing seizures, FND, open neurological deficit, confusion, okay. So so it's simple to remember, like it, like the patient has fever because there is infection, patient will be in shock, because that's why it is called toxic shock syndrome, and there is involvement of 3 or more organ systems, any of them, okay. So you may be given, like or maybe the patient may present to you that I have some infection, mild infection earlier, upper respiratory tract infection. They may not give you a tampon, or they may not give you posterior nasal packing. They may give you, the patient has, I had some, the patient may present to you, I had some infection earlier. Now I have a rash, okay, and you examine the rash is very severe on the palms and the soles, and you examine the patient, the blood pressure is very low and CPK is very high, okay, and also there is a damage to the liver, damage to the mucous membrane, the CNS problem. Patient may come to you in confused state. Okay, so these all indicate that the patient has toxic shock syndrome because of the production of exotoxin. This exotoxin is very important, which acts as a super antigen. So treatment is because since it is Staph aureus, we give the patient vancomycin plus clindamycin. So clindamycin will, it covers gram positive and anaerobes, but it is also added when we have to block this toxin production. So clindamycin, it will block this toxin production. So that's why we add clindamycin here. Okay. So that's for toxic shock syndrome. It can be caused by streptococcus infection also. There is a other criteria for streptococcus, but that's different. Okay. So it is not that only staph aureus causes toxic shock syndrome. It can be caused by streptococcal infection also, and this is the major criteria which I told: fever, hypotension, and there is involvement of three or more organ system, as I said: gastro, CNS, mucous membrane, okay, muscular, okay, clear. CNS involvement, mucous membrane, muscular involvement, high CPK level, okay, and liver involvement, renal involvement, raised bun creatinine, or okay, clear. Mucous membrane radishness, conjunctivitis or vaginitis, okay, clear. So that's toxic shock syndrome, simple. Any questions? Okay, next we come to infection of the skin and the subcutaneous tissue. So that is cellulitis. And this is also mainly caused by Staph aureus and group A beta hemolytic streptococcus, which is Streptococcus pyogenes. So the patient has infection. So whenever there is infection or inflammation, the patient has red, hot, tender, swollen thing, means the organ wall. So here also it is red, as you can see, tender. The patient will have severe pain. You touch the patient will start wincing. Okay, red, hot, tender, swollen. Okay, and also it is means the temperature will be higher. So these are the characteristics. Whenever there is inflammation occurs or infection occurs, there is red, hot, tender, swollen thing. Okay, and also the patient will have. So this is if the patient has some mild cellulitis, like just infection is limited to the superficial tissues. Okay, so in that case we have only red, hot, tender, swollen joint, this limb. Okay, but if it's cellulitis, it is generalized, it is not treated, it can spread. It can spread, and the patient will have signs of systemic infection, like the patient has fever. So whenever fever is present, that indicates that there is systemic infection. Okay, fever, patient has malaise. Okay, shock can occur if the infection is very severe. It can lead to shock, confusion. Okay, these things are present. Okay, in severe cellulitis, in systemic cellulitis. Okay, so treatment of mild cellulitis, it is clindamycin, cephalexin, dicloxacillin. Okay, like the patient has these things only: red, hot, tender, swollen joint. Okay, so as I said, it is mainly caused by Staph aureus. So you'll give the patient oral antibiotics. Okay, so you give the patient, patient comes to you with these symptoms. So what is the next thing you will do? You will give the patient antibiotics, and you have to treat the patient in the outpatient department. We will not hospitalize the patient. So give the patient oral antibiotics because you are not hospitalizing the patient. So give the patient oral dicloxacillin, cephalexin, clindamycin. Okay, so cephalexin is the first generation cephalosporin. Okay, and if it is a case of MRSA, if it is because of methicillin resistant Staph aureus, so dicloxacillin, these are methicillin sensitive Staph aureus. Dicloxacillin, okay, oral dicloxacillin, oral cephalexin. So these are oral antibiotics which are effective against Staph aureus. But if the patient has methicillin resistant Staph aureus, then we give the patient vancomycin, oral vanco, or if vanco allergy, we can give daptomycin. Okay, Tigecycline can be given. So these are Bactrim can be given, doxycycline can be given. Okay, so doxic is also effective against community-acquired MRSA. Doxycycline is effective against community-acquired methicillin-resistant Staph aureus. So doxycycline, Bactrim, that is trimethoprim sulfamethoxazole, that is also effective against methicillin-resistant Staph aureus. Okay, so these are the antibiotics which are effective against methicillin-resistant Staph aureus. Okay. Uh, and if the patient has severe signs like these things happen, then we give intravenous antibiotics. Okay, so instead of decloxacillin we give anaphylacin, instead of cephalexin we give cefazolin. Okay, so these are all intravenous effective against Staph aureus, and in case of methicillin resistant Staph aureus we give the patient vancomycin or tigecycline. Also, another thing in cellulitis is there is history of some break in the skin, like the patient has some tinea infection, or there can be some infection earlier also. Okay, so that causes a break in the skin, so the infection can spread deeper and there are higher chances of cellulitis. Okay, so that's for cellulitis, in which we have infection of the skin and the subcutaneous tissue. Okay, uh, so we have mild, these things, and we have severe, these things. Okay, clear. Okay, next is erysipelas. Okay, this is also a picture of cellulitis, as you can see, mild cellulitis. Okay, okay, now this is erysipelas. So what is so that is infection of the superficial layers of the skin only, and the difference here is it has sharply demarcated margins. Okay, so this is a characteristic feature in case of erysipelas. The patient has red, hot, as it is reddish, hot, swollen. There is some swelling. Okay, and maybe there is tenderness. Maybe there is some mild tenderness. Okay, but the characteristic feature here is this is also an infection, so the patient will have these features. Okay, and but the characteristic feature, the differentiating point is well demarcated margins. Okay, so this is erysipelas. Mainly it is caused by same group A beta hemolytic streptococcus or maybe Staph aureus. So streptococcus pyogenes or Staph aureus, and there is infection, there is a history of break in the skin or some trauma. Okay, treatment is penicillin or erythromycin. So this is erysipelas. So infection. So how will you differentiate between erysipelas and cellulitis? That is, this is infection of the superficial layers of the skin, and also there is well demarcated margins. Okay. Next we have impetigo. So this is another cause of infection of superficial layers of the skin. Okay. So this erysipelas or impetigo, they are infection of the superficial layers of the skin. When the infection spreads deeper, this is called cellulitis. Infection of the skin and the subcutaneous tissue, that is cellulitis. Okay. But if the infection is limited to the superficial layers only, that is called erysipelas. Okay. Sorry, erysipelas or impetigo. Okay. So here also it is infection of the, as I said, superficial layers of the skin, and it is mainly caused by Staph aureus. Erysipelas was GABS by group A beta hemolytic streptococcus or streptococcus pyogenes. This is caused by Staph aureus. Okay, and mainly it is of two types: bullous or non-bullous. And in bullous type, as we know, there is blisters, and non-bullous type it is vesiculopustular type. Okay, and so this is a vesiculopustular type. So these pustules, these vesicles, they rupture forming honey colored crust. So this is honey colored crust. So whenever you see honey colored crust, generally it is impetigo. Okay, so we have bullous and non-bullous type. So this is a type of non-bullous type. Treatment is topical mupirocin or oral erythromycin. Or sorry, topical mupirocin or oral erythromycin. Okay, Topical, okay. Clear? So that is impetigo, honey colored crust. Clear? Okay. So we start with superficial, as I said, I am repeating again, superficial layers of the skin, erysipelas or impetigo, infection of superficial layers of the skin. Okay. We go deeper. We go deeper, it becomes cellulitis. Okay. And we go for, so it becomes cellulitis, that is infection of the skin and the subcutaneous tissue. Now we go further deeper, the infection spreads further deep inside. Okay, so then it is called necrotizing fasciitis. So there is involvement of the fascia, the muscles also. In cellulitis there is infection of the skin, involvement of the skin and the subcutaneous tissue. But now the infection spreads deeper, there is involvement of uh, with the fascia and the muscles, so that is called necrotizing fasciitis. Okay. So the organisms release toxin, and so they will cause damage to the tissues and also necrosis, leading to sepsis and even death of the patient. So the treatment of necrotizing fasciitis, it is surgical debridement. Okay. So we have two types of necrotizing fasciitis, which is type 1 and type 2. Okay. And this is also honey colored crust, as you can see. This is bullous impetigo. Sorry, this is bullous impetigo. Okay. So this is, as I told, we have non-bullous and we have bullous. So this is bullous. Okay. Impetigo. So, and this is a necrotizing fasciitis. Okay. So you can see the skin discoloration. There is edema, red, hot, tender, swollen arm or finger, whatever. Okay. The organ, it is red, hot, tender, swollen. There is reddishness, there is edema, there is tenderness, there is swelling. Okay. But there are discoloration of the skin also, because it involves the deeper structures. Okay. There is crepitus also, because it may involve anaerobes, gas forming anaerobes. Okay. So there is crepitus. So as I said, necrotizing fasciitis, it is of two types, type 1 and type 2. Type 1, it is polymicrobial, and type 2, it is mainly caused by streptococcus. Okay. So type 1, type 2. So type 1, it is polymicrobial. So as I said, staph, streptococcus, E. coli, and mainly occurs in diabetic patients. And type 2, it is there is no means there is history of some trauma, and it is mainly caused by group A beta hemolytic streptococcus, that is streptococcus pyogenes. Okay. Now there is a characteristic feature is there is redness, there is blister formation, and also skin color changes. Skin color, as you can see, purple color, and also the patient won't be able to move his limb. So there is red, hot, tender, swollen limb. Okay, but another characteristic feature is there is a color changes. Color changes, as you can see. Patient won't be able to move the limb. This is also characteristic in case of necrotizing fasciitis. Whenever you see in any question or the patient presents to you, I am unable to move the limb. So that is necrotizing fasciitis. No movement, and inability to move the limb. Okay. Another thing is like there is woody induration, very hardness. Okay, so this is also characteristic, woody induration. Okay, so these are the characteristic features. Infection can spread from some other area also, like the patient has diabetic foot, and there is osteomyelitis, there is a abscess formation, there is cellulitis. The infection can spread deeper, causing necrotizing fasciitis. That is also polymicrobial. Okay. And when necrotizing fasciitis involves the male perineum, it is called Fournier's gangrene. Okay, so this is Fournier's gangrene. There is gangrene, as you can see, involving the male perineum. Okay, so you can see the characteristic skin color changes. Patient is unable to move. Okay, woody in duration. These three points are very important. Diagnosis will be MRI. So we take the MRI. Why? Because there is a uh, it will show gas and the extent of damage. CPK will also be very high. We will take blood culture, tissue culture. Okay, treatment is surgical debridement because the portion is dead, and we give the patient intravenous antibiotics. Antibiotics are broad spectrum. So vancomycin. So in type 1 necrotizing fasciitis, I told it is polymicrobial. So staph, streptococcus, anaerobes, and it can be anything. So we give patient vancomycin that will cover staph plus piperacillin tazobactam. So piperacillin tazobactam, it is also a broad spectrum antibiotic which cover gram positive, anaerobes, and also gram negative. Okay. So staph will be covered by vancomycin, and piperacillin tazobactam will cover this other organisms like anaerobes, gram positive and gram negative. Or we can use combination of vancomycin plus imipenem, meropenem. So they will also cover these things. Or a combination of vancomycin plus cefepime plus metronidazole. Okay, so vancomycin will cover Staph aureus and also other gram positive. Cefepime will cover Pseudomonas or other gram negatives plus metronidazole, which will cover anaerobes. Okay, so this is the combination. So this way we can move. Okay. So whenever we suspect streptococcus, we will add clindamycin because clindamycin will block toxin production. Okay. So wherever we suspect streptococcal infection, we will add clindamycin. So vancomycin plus imipenem plus vancomycin plus cefepime plus metronidazole, and we can add clindamycin, which will block toxin production. Sorry, not metronidazole, vancomycin plus cefepime plus clindamycin. Okay, this combination we can use. So Vanco will cover Staph aureus, Cefepime will cover gram negatives, and Clinda will cover anaerobes, and it will also block toxin production. Okay, so this is how we treat the patient. Okay, diagnostic test of choice, it is tissue culture. We can also go for MRI. So if you are asked what is the next thing you will do, patient comes with the these symptoms. So first thing is always stabilize the patient. Okay, because the patient may be in shock. Next thing is we go for blood culture, tissue culture, and also MRI, and then we start giving the patient antibiotics. Okay, plus surgical debridement. So this is the next step. Okay, clear. So that's necrotizing fasciitis. So that is the infections. Okay, so we started with superficial, and then we went deeper and deeper into the tissues. Okay, erysipelas, impetigo, cellulitis, mild cellulitis, severe cellulitis, and then ultimately necrotizing fasciitis with involvement of the fascia, muscles, high CPK. Okay. Okay. Next, we come to various reactions, drug reactions or other things. So next topic is urticaria. So in urticaria also, as I said earlier, also there is generalized rash. There is generalized rash, and which is evanescent, means it appears and then it disappears. Okay. It appears and then it disappears. Okay. Like few minutes to hours, and it is itchy red wheels with sharp borders. Okay, so as you can see, we have sharp borders. So this is characteristic: itchiness, reddish, and there are sharp borders. So whenever you see a dermatological condition, you have to look at the borders. Okay, so there we have sharp border. Dermographism will be seen. We scratch the skin, it causes wheel formation. Okay, so that this is called dermographism. This is wheel formation. And there are some drugs. What are the main drugs which cause urticaria? That is NSAIDs and ACE inhibitors. If you have a lot of choices, these are the two main drugs which cause urticaria: NSAIDs or ACE inhibitors. You may be given allopurinol, you may be given anti-epileptic drugs, but these are the two main categories of drugs, okay, which cause urticaria, and it is diagnosed clinically. So if you are asked, okay, what is a patient has, you suspect urticaria. So what is the next thing you will do? What is the next thing is you will do? Avoid the allergen. You will not pick up rash test. So whenever there is allergy, the next step is avoid the allergen, okay? Clear? You will not go for rash test. Clear? Any questions? No rash test. You suspect urticaria, avoid the allergen. Next. And if there is no relief, we give the patient antihistamines like cetirizine, loratadine, fexofenadine. And then if still no relief, we give the patient steroids or calcium channel antagonists. So antihistamines. Okay. No relief, add calcium channel antagonist or steroids. Generally, we give the patient steroids. Okay. This is how we move. This is not done. Okay. Clear, simple. Evanescent rash is simple. So this is rash test, radioresorption test. So it is done when we want to detect the allergen. Okay. Radioallergosorbent, radioimmunoassay, concentration of antigens. Okay. Concentration of antigens. So we have to suspected allergen. We want to detect this suspected allergen like dust. Okay, maybe there is some plastic or rubber, latex. Okay, so we want by doing this test, we want to detect which is the allergen. By doing this test, we want to detect the concentration of the antigen. Okay, clear? Any questions? This is how it is performed. So as you can see, the patient is having some swelling here. Okay, patient is allergic to these substances. Okay, clear? So that was for urticaria. Next is fixed drug reaction. So fixed drug reaction, it is also caused by mainly same drugs, ACE inhibitors, NSAIDs, anti-epileptics. Okay, and characteristic feature is the rash occurs at the same location again and again. Whenever the patient takes drug, patient takes ACE inhibitor, the patient may have rash on the back. Patient takes it again the rash appears on the back. So this is called fixed drug reaction. Okay, there can be itching also. There can be peeling of the skin in very severe cases, and treatment is avoid the drug. Okay, so that's a fixed drug reaction. Again, same again occurring, the rash occurring again at the same location. Okay, again and again, again and again. Okay, so this is fixed drug reaction. This is characteristic. Clear, simple. Okay, next is a photosensitivity. So it is basically contact dermatitis, type 4 hypersensitivity reaction, but it is dependent upon the UV light. Patient takes some drug, tetracycline, doxycycline, okay, thiazide diuretics. So these are the drugs which are involved in photosensitivity, mainly tetracycline or thiazide diuretics. Sulfur drugs can also cause photosensitivity reaction, okay. So basically, it's a type 4 hypersensitivity reaction. There is involvement of the T lymphocytes, but it is dependent upon ultraviolet light. Okay, so when the patient takes drug, there is activation of the T lymphocytes, but when the patient is exposed to sun, there is a rash on the sun exposed areas. Okay, so it is just like exaggerated sunburn. Okay, so avoid the drug. Treatment is again avoid the drug, apply sunscreens, use topical steroids. So treatment is the same. Okay, so basically allergic contact dermatitis, that is photosensitivity. Okay, clear? Okay, so these are mild drug reactions. Next, we come to slightly severe drug reactions, which involve scar. Scar. This may not be asked what is scar, but you should. These are the characteristics. Means these severe drug reactions come under the category of scar. Okay, so scar, it is severe cutaneous adverse drug reaction. Severe cutaneous adverse drug reaction. Okay, so that is scar. So characteristic feature in scar, it is there is mucosal involvement. First thing is mucosal involvement. Mucosal involvement with blisters. Okay, okay, with blisters. Also, there is skin necrosis. This is also characteristic. Very, very characteristic. Skin necrosis. Okay, and in very advanced cases, there can be hypotension. Okay, patient can go into shock. These are the main characteristics: skin necrosis and with mucosal involvement. In severe cases, patient can go into shock. So this is scar, severe cutaneous adverse drug reaction. Okay. So we have categories of scar, which includes erythema multiforme. This is erythema multiforme. Erythema multiforme on one end of the spectrum and toxic epidermal necrolysis on another end of the spectrum. And in between, we have Stevens-Johnson syndrome. Okay. So this is erythema multiforme. Generally, it is caused by infection, by herpes simplex, by mycoplasma. Okay. Or maybe coccidioides infection, that can also cause erythema multiforme, as we know from infectious disease. Okay. So may be caused by drug reactions also. So in erythema, as it is a type of scar, so there will be mucosal involvement. Patient will have involvement of the oral mucosa or vaginal mucosa. Okay, conjunctival involvement can be there in erythema multiforme because it is a type of scar. Okay, and so the patient will have target lesions. So there is a central dusky zone. This is, as you can see, followed by pale region. This is pale region, and there is a ring of redness. Okay, so this is mucosa, erythema multiforme. Okay, so these things are easy. Erythema marginatum in rheumatic heart disease, in rheumatic disease. Okay, erythema marginatum, erythema nodosum in tuberculosis, histoplasma, inflammatory bowel disease, sarcoidosis. Erythema chronicum migrans in Lyme disease. Erythema infectiosum, that is fifth disease, that is slap cheek appearance. So these things are easy to remember. Okay. So basically, it is of two types. We have erythema multiforme minor or erythema multiforme major. So there is lesser skin involvement with only one mucosal surfaces. So erythema multiforme minor, as the name suggests, it will be minor. So there is skin involvement with the mucosal involvement. Okay, and we have major. So in major, we have two or more mucosal surfaces are involved. Like we have conjunctiva involvement, or oral mucosa, or we have genital mucosa is involved. Okay, so minor we have just one mucosa with skin involvement. Major we have two or more mucosal surfaces. Okay, and erythema multiforme major, in some of the books it is given, it is called Stevens-Johnson syndrome, but there is a lot of overlap. Stevens-Johnson syndrome is slightly different thing. Okay, so erythema multiforme major or in Stevens-Johnson syndrome, there is significant overlap. We cannot say they are the same thing. Okay, They can be, but they are different things. Okay. So erythema multiforme major, it overlaps with Steven Johnson syndrome. Okay. So we come. So this is for erythema multiforme, minor or major, and this major it overlaps with Steven Johnson syndrome. So next we come to Steven Johnson syndrome. So it is also hypersensitivity reaction with skin involvement and mucosal involvement, and there is involvement of two or more mucosal surfaces, as I said, because it overlaps with erythema multiforme major. So there is like oral mucosa, genital mucosa, conjunctival mucosa. Okay, and also there is prodrome. This is characteristic in case of Steven Johnson syndrome, and also in case of TEN. There is prodrome. Patient may have fever. Okay, myalgia, arthralgia, nausea, vomiting also can be there, and the patient will have then macules, papules, blister formation. Okay, so this is characteristic of Steven Johnson syndrome in 10. There is prodrome. Okay, and there can be peeling of the skin in later situations. There is something called S4, staphylococcal scalded skin syndrome. Staphylococcal scalded skin syndrome. This situation, it looks like toxic epidermal necrolysis, but in this case, S4, there is no prodrome. Okay, this way you can differentiate. Very important. Okay. So coming back to Steven Johnson syndrome, the patient will have two or more mucosal surfaces are involved, and also the patient has prodrome. Okay, plus there is a skin involvement, and mainly there is immune complex mediated hypersensitivity reaction. And drugs are there is a long list of drugs. Any drug can cause the Steven Johnson syndrome or 10. Okay, quinolones can cause any antibiotic, sulfa drugs, anti-epileptics, NSAIDs, ACE inhibitors. Okay. So there is prodrome, there is involvement of the mucosa, two or more mucosa, and the third characteristic here is that there is skin necrosis. Skin necrosis, okay. Clear? In both Steven Johnson syndrome and toxic epidermal necrolysis. Okay, this is means this is a characteristic of scar. This thing I told earlier also. Okay, so there will be blisters in the mouth because there is involvement of the mucosa. So blisters in the mouth, in the genital mucosa. Patient will say, I am unable to drink and eat because I have so many ulcers in the mouth. Also, hemorrhagic crusting. So another feature of Steven Johnson syndrome is hemorrhagic crusting. Okay, this is also characteristic. This is hemorrhagic crusting. So it is involving the mucosa, as you can see, plus there is crusting. Okay. And there is involvement of less than 10% body surface area. And if there is involvement of more than 30% body surface area, that is toxic epidermal necrolysis 10. Okay. Simple thing. Treatment is stop the drug. So how will you treat Steven Johnson syndrome, or the patient has 10? So basically there is no difference between Steven Johnson syndrome and 10. Okay, in 10 also there is involvement of the two mucosal surfaces. Okay, and there is skin necrosis. The patient can go into shock, but basically there is involvement of more than 30% body surface area in case of 10. Okay, And also the patient Nikolsky sign will be positive. We press the skin splits off. So Nikolsky sign, it is positive in case of pemphigus, in case of staphylococcal scalded skin syndrome, that is S4, and also in case of 10. So three conditions. So how will you treat the patient as Steven Johnson syndrome or 10? How will you treat the patient? You will stop the drug. First step is always stop the drug and then admit the patient in the burns unit. Admit the patient in the burns unit. Steroids and antibiotics, they are never given. They will aggravate the condition. Steroids and antibiotics, they are never given in case of Steven Johnson syndrome or toxic epidermal necrolysis. Okay, they are never given. Clear? So that is for so stop the drug. First step, admit the patient in the burns unit, because you treat the patient just like a burn patient. You give the patient a lot of intravenous fluids. You do dressings because there is a high chance of infection. Okay, but steroids or antibiotics, they are not given. Clear? So that's Steven Johnson syndrome or TEN. Okay. This is a picture of toxic epidermal necrolysis. You can see severe involvement of the more than 30% body surface areas involved. There will be skin necrosis and also pemphigus. This Nikolsky sign will be positive, and also oral mucosa, gentle mucosa, two or more mucosal surfaces are involved. Okay, clear? So that's 10. Okay, toxic epidermal necrolysis. So that's for drug reactions, scar. Okay. This is also, you can see, 10. Whole skin is involved. And this is S4. Okay. So as for staphylococcal scalded skin syndrome, it is caused by, as the name suggests, Staph aureus. Okay. And the patient does not have any prodrome. No prodrome here. In case of 10 and Steven Johnson syndrome, there was prodrome, but here there is no prodrome. This is a very important point. Okay. No prodrome, no mucosal involvement. This is another point of difference. No mucosal involvement. Okay. And another point of difference is there is uh, no skin necrosis. So no oral mucosa, no gentle mucosa. If the patient comes to you that I cannot swallow food, I cannot drink liquids because I have a lot of ulcer in the mouth, so that it cannot be S4, because in S4 there is no mucosal involvement. Okay, and also no skin necrosis. So these are very important points. May not be given in any book. Clear? So the patient has infection elsewhere in the body, just like in toxic shock syndrome, sore throat, abscess, pneumonia, and there's liberation of the toxin. So this toxin will cause skin peeling, okay, blister formation, and so there is positive Nikolsky sign because it damages the desmoglein. So if you press the skin, there is the layer splits off. Okay, and also these are signs, and the patient also has perioral crusting. In case of Steven Johnson syndrome, we had hemorrhagic crusting. Here you can see perioral crusting. So there is lot of crusting around the mouth. Okay, there is no involvement of the mouth, no involvement of the mouth, but there is perioral crusting. So this is characteristic. Another characteristic of S4. Okay. Culture, if you culture those blisters, this is also very important. If you culture these blisters, it is negative because it's a toxin mediated process. This is a very important point. This may be asked. Okay, you culture these vesicles and it is negative. So this is how, these are the concepts. You implement those concepts in the questions or in the real clinical practice. Okay, big very reputed doctors, they have these points in the mind. They have these formulas of mathematics in the mind, and they keep implementing those formulas in the real life. Patient comes to you, patient has a lot of crusting around the mouth, but there are no lesions in the mouth, and patient does not have any prodrome. Okay, so that points toward S4. So this is how you can diagnose the case. Okay, in the real clinical, in the clinical practice also. Clear? So again, what we will do is, the next step is we'll admit the patient in the burns unit, and we give intravenous antibiotics, vancomycin, okay, tigecycline, daptomycin. quinapristine, dalfopristine, linezolid. So these are all anti-staph antibiotics. Okay. In case of 10 toxic epidermal necrolysis Stevens-Johnson syndrome, we do not give antibiotics, but here, so we are giving antibiotics. So this is how we differentiate. Okay, clear? Perioral crusting, no prodrome, no mucosal involvement, no skin necrosis. Clear? Any questions? This is Nikolsky sign. You can see splitting of the layers of the skin. So it is positive in 10 in case of pemphigus and also in case of S4. Okay, clear? Okay, next is folliculitis. So means generally caused by Staph aureus. So like the patient has pustules like these around the follicles. Okay, treatment is that tetracycline, doxycycline, clindamycin, erythromycin. If it is not treated, it will lead to furuncles. This is furuncles. Slightly not clear. Furuncle. If it is not treated, then it is carbuncle. This is carbuncle. This is carbuncle. So folliculitis not treated, furuncles. If it is not treated, carbuncle. Treatment is antibiotics. Okay. Anti-staph antibiotics. Okay. Clear. Next is atopic dermatitis. So as you can see, this is a typical example of atopic dermatitis. So it's a type 1 hypersensitivity reaction. Okay. Okay. This is easy to remember. Type 1 hypersensitivity reaction, everyone knows. But there is personal or family history of asthma or atopy. Okay. So they will not give you a question like 15-year-old child, 15-year-old boy has this atopic dermatitis. There must be some family history. There must be some family or personal history. Okay. So generally it starts in the childhood. So there, if they give you a question like the patient has a rash in case of atopic dermatitis or contact dermatitis, it is the same. There are vesicles, pustules, papules, vesicles, pustules, which liberate fluid. Okay, and there is a itchiness also. But in case of atopic dermatitis, it is uh, there is a personal history. Okay, it starts in the childhood. If there is no personal history, it cannot be atopic dermatitis. This is one important point. Very important point. There has to be some personal history. Okay, from childhood. Okay, 25-year-old male, 20-year-old patient. Okay, they will not present with atopic dermatitis without being without any symptoms in the childhood. Okay, if there are symptoms like 20-year-old patient presents with vesicles, okay, itchiness, so that cannot be atopic, it can be contact dermatitis. Okay, this is one important point. So lesions will be the same as in contact dermatitis. There is itchy papules, plaques, erythematous base. And so another important point is relapsing or recurrent course. They occur again and again. You prescribe steroids or creams to the patient, and they will occur. Hydrocortisone cream generally it is prescribed on the face because it is a mild steroid. Okay, so whenever you have to apply any steroid on the face, generally they use hydrocortisone. Betamethasone is slightly potent, so we do not use it on the face. So hydrocortisone is used mainly on the face. So you prescribe steroids, the lesions disappear and then they occur again. Okay. So first point is like type 1 hypersensitivity reaction, easy to remember, or there is a presence of vesicles, pustules, okay, which liberate fluid. Second important point is there is personal history. It is there is some personal or family history. Okay, it starts from childhood. Third important point is there is recurrent or relapsing course. It occurs again and again. Okay, and mainly occur in the babies on the cheek and the neck. And the wherever there is dryness, it will aggravate this atopic dermatitis. Okay, so that's why generally we should not take a hot water bath daily. Okay, because it causes it the moisture of the skin it is lost if we take daily hot water bath. Okay, so generally it is suggested you should take cold water bath also. Okay, if you keep on taking a hot water bath, it will the moisture of the skin will be lost and you will start having itchiness. Okay, the skin will lose its texture. Okay, so So that's why we recommend that the cold water or mild lukewarm water should be used in babies to prevent this or to treat this atopic dermatitis. Okay, if you apply steroid, there will be resolution of the symptoms. This rash will disappear. Patient applies hydrocortisone cream on the baby, and the mother applies hydrocortisone cream on the baby. The lesions will disappear suddenly. So this is called atopic dermatitis. Okay, this is a characteristic feature like steroid, triamcinolone, hydrocortisone, or emollients like petrolatum can be given. Okay, because emollients like petrolatum, this is also very characteristic. These are all very important questions. So they form a layer on the skin. Petrolatum, when you like Vaseline, when you apply it, it forms a layer on the skin and it will prevent the loss of moisture. Okay. Otherwise, if we don't use these emollients, or if you don't use steroids, or if you continue bathing the child in warm water, so what will happen? There will be dryness and patient will scratch, so that can further aggravate the dryness leading to dermatitis. So each cycle will occur: dryness, scratching the skin, further aggravation of dermatitis, further aggravation of the dryness leading to further aggravation of symptoms. Okay, so this is called itch cycle. So it has to be prevented by giving these treatment. Okay, so avoid excessive warm water bath. So area which is wet. So as I said, dryness aggravates atopic dermatitis. Okay, one thing is personal history. Second thing is recurrent course, type one hypersensitivity reaction. Another point is that there is dryness will aggravate the condition. So wherever there is wet area, it will never have this atopic dermatitis. Like the diaper area will is never it is never involved as it remains wet, so it will be something else. So if the diaper area has rash, it can be contact dermatitis, it cannot be atopic dermatitis. This is also very important point. Okay, so emollients like petrolatum, when you apply to the skin, they will prevent the moisture, they will prevent loss of moisture from the skin, so they will cause relief of symptoms. So in many of the questions and real practice also, you will see that we apply steroids on the skin, the lesions disappear. We apply emollients on the skin, the lesions disappear. So what is the cause? What is the disease? It is atopic dermatitis. Okay, and it will never occur on areas where there is uh, like the area it is wet. So if you see diaper rash, okay, it cannot be atopic, it is contact dermatitis. Okay, so this is, as you can see, diaper area is involved. Okay, this is the diaper area is involved. It is not atopic dermatitis, it is a type of contact dermatitis. Okay, I will come to that. Okay, clear. And excessive scratching of the skin will cause lichenification. So lichenification is the thickening of the skin. Okay, so this is lichenification, thickening of the skin. So cheek, neck area is involved, face mainly occur in the face. So that's for atopic dermatitis. Okay, clear. Any questions? Next we have contact dermatitis. So these are the types of atopic dermatitis. In infants, it occurs on the extensor surfaces. Why? Because they generally they crawl. Infants crawl, so this area will become dry. These areas will become dry. Okay, so that will cause a, if this is dry, it can cause this area. Generally, it is not seen in this area. Okay, these are the areas mainly seen in head, forehead, or cheeks or neck area. Childhood may be seen in antecubital fossa. Okay, so here they are occurring on the extensor surfaces. Here they are occurring in the flexural folds, popliteal fossa, antecubital region. Okay, this is also characteristic. In the infants, it occur mainly on the extensor surfaces because the infants keep on crawling. So crawling, this area becomes dry, causing atopic dermatitis. Okay, here they are occurring on the flexural surfaces. Okay, this is also characteristic. Very important point. Clear. Next, we have contact dermatitis. So this is a contact dermatitis. The lesions are the same, almost the same as atopic dermatitis. Okay, It's a type 4 hypersensitivity reaction. So it will cause activation of T lymphocytes. So mainly, as you can see, we have vesicles, papules with erythematous base with serous discharge. Okay. So like the patient went somewhere for camping. This is a typical question. Patient went for camping and he's exposed to this uh, poison ivy, and there's rash on the point of contact of the leaves. Patient has some bracelet that causes this rash. Okay, patient wears gloves that causes this rash. That is all contact dermatitis. Okay, so treatment is avoid this allergen. Okay, and we can use topical steroids, topical antihistamines. Burroughs solution can also be used, which contains aluminum acetate. Okay, sorry, aluminum acetate. So Burroughs solution. So that's uh, contact dermatitis, and it is of two types mainly. We have irritant or allergic. So irritant contact dermatitis or allergic contact dermatitis. Okay. Okay. So we have two types of contact dermatitis: irritant or allergic. So what is this? So it is a type of irritant contact dermatitis. It is seen in hairdressers due to chronic washing. Okay. And it gets relieved on the weekends. Patient will say, I have aggravation of the symptoms on when I do my job, and when I come home, there is relief of symptoms, especially on the weekends. Okay, this is a characteristic. So this is irritant contact dermatitis due to excessive hand washing. Diaper dermatitis, it is also a type of irritant contact dermatitis due to constant contact with the secretions. Baby keeps on urinating, defecating, so the surrounding area will have dermatitis. So that's irritant contact dermatitis. Okay. So treatment is avoid tight fitting diapers. Okay. We can use zinc oxide for diaper dermatitis. Topical steroids can be used. Okay. So that's irritant contact dermatitis. So this is diaper dermatitis, as you can see. I will come to that later. So this is diaper contact dermatitis. So it is basically irritant. Okay. There is a sparing of the genitocrural folds, and also there is no satellite lesions. There are no satellite lesions, and there is sparing of the genitocrural folds. Okay. So this is a Candida infection. There are satellite lesions. There are satellite lesions here. Involvement of the genitocrural folds. Okay. And also tomato red plaques. Look like tomato red plaques. This is characteristic of three things: satellite lesions, tomato red plaques, and involvement of the genitocrural folds. So this is called Candida infection. Okay. This is irritant contact dermatitis. There are no, as you can see, there are no satellite lesions. There is sparing of the genitocrural folds. Okay, no involvement, and also no tomato red plaques. Okay, this is called irritant contact dermatitis, means diaper dermatitis, which is a type of irritant contact dermatitis. Okay, clear. Next we have a allergic contact dermatitis. So this is allergic contact dermatitis, mainly occur in surgeons due to allergy from the rubber, and there's involvement of the dorsal surface of the hands. Okay, so this is allergic contact dermatitis. Okay, and how will you diagnose? So what is the next step you will do? If you have to diagnose the situation, the next step is patch testing. So it is a gold standard for diagnosing Candida, this contact dermatitis. Treatment is steroids. Okay, patient is asked to avoid the allergen and also give the patient steroids. Okay, so you suspect contact dermatitis. What is the next thing you will do? Patch testing. Patch testing is the standard test. And if you do not see this in the choice, you can pick steroids. Okay, clear. Clear. Any questions? This is Candida rash, and the treatment is topical, just like in other fungal infections, topical clotrimazole or nystatin. Okay, clear. Okay, next is psoriasis. So, as we know, it's simple. It's occur on the extensor surfaces, like the knee and the elbow, and there are well demarcated plaques with silvery scales. So, well demarcated plaque with silvery scales, that is psoriasis. Okay, which is well demarcated with silvery scales. Positive Koebner phenomena, like the lesions are occur at the site of the trauma, and when we remove these scales, when you scrape off these scales, you will see tiny capillaries. So this is called positive Auspit sign. Okay, diagnosis will be by biopsy, and biopsy will show neutrophilic infiltrate. And in very advanced cases, there is onycholysis, as we know from rheumatology. There is onycholysis, which is separation of the nail from the nail bed. Okay, so treatment here also is steroids or emollients. Okay, on elbows we can use betamethasone. So we use strong steroids on elbows or the knees. Okay, and on face we use low potency steroids like hydrocortisone. Coal tar products can also be used like calcipotriene, and if psoriasis it is generalized, then we go for puva therapy. Methotrexate, it can be given if the patient has psoriatic arthritis, and the patient has psoriasis in the last so many years. So then we use methotrexate or TNF alpha antagonist. Now there are drugs which can aggravate psoriasis. These five classes of drugs are very important. Okay, beta blockers, ACE inhibitors, anti-malarials like chloroquine, NSAIDs, and lithium. So these are the five drugs which aggravate psoriasis. Very important. Beta blocker, ACE inhibitors, anti-malarial drugs, NSAIDs, and lithium. Okay, clear. So that's psoriasis. Simple. Diagnosis will be skin biopsy. Generally, it is not performed. If you see psoriasis, what is the next thing you are asked? If you are asked what is the next thing will be treatment. Okay, and we can stop the drugs which cause aggravation of psoriasis. So that's psoriasis. Next, we have lichen planus. So this is lichen planus. So we have five P's: pruritus. There will be itching, polygonal, purple, papular, and planar. Five P's. And mainly they occur on the flexural surfaces: papular, polygonal, pruritic, planar, and purple. Okay, so these are occur on the flexural surfaces, wrist, and there are whitish striae which are called Wickham striae. These are Wickham striae, as you can see, whitish. Clear. Here, okay. And they can involve the gentle mucosa, glans penis. Diagnosis will be biopsy. So in case of psoriasis, the biopsy showed epidermal hyperplasia with neutrophilic infiltrate. Here biopsy will show hyperkeratotic epidermis. Whenever the word hyperkeratotic comes, these are Wickham striae, whitish. So whenever the word hyperkeratotic comes, that means thickening of the stratum corneum. Lichenification means thickening of the skin. Hyperkeratotic lesions mean thickening of the stratum corneum, the upper layer of the epidermis. Okay. So when we do biopsy here, we will see hyperkeratotic epidermis, thickening of the stratum corneum. Treatment is against steroids, PUVA therapy, positive Koebner phenomena here, lichen planus also, and it is associated with hepatitis C infection, as we know. So when the patient has liver disease, we will go for PCR, polymerase chain reaction. Patient has liver disease, patient has jaundice, and the patient comes with this kind of rash. So we'll go for PCR to rule out hepatitis C infection. Okay, clear? And these are also Wickham striae. Okay, whitish. This is positive Koebner phenomena. So it occur on the areas of trauma. Okay. There is something called lichen simplex chronicus. So lichen simplex chronicus means there is just thickening of the, there is a hyperkeratosis, there is thickening of the stratum corneum, like there is some trauma, you start itching, so that will lead to further, which will lead to scratching, and that will lead to development of rough surface. So this is called lichen simplex chronicus. Lichen simplex chronicus, okay. So there is hyperkeratosis, okay, because of the trauma causing itching, okay. Next is a pityriasis rosea. So this is pityriasis rosea. So you have a light brown scaly eruption. First, there is some scaly eruption, light brown scaly eruption which occurs, okay, and it has wrinkle appearance. This is called Herald patch. So you can see a wrinkle appearance. Okay, this is characteristic. And after some time, after 1 to 2 weeks, don't have to remember 1 to 2 weeks, there is a multiple macular rash on the trunk along the cleavage line, so which is in the Christmas tree pattern like this. So this is called pityriasis rosea. No treatment is required, and potassium hydroxide test, it is negative. Okay. Okay, so this is pityriasis rosea. First, a herald patch with the uh, brown color, brown color, that is a fawn color, wrinkle appearance, and then after 1 to 2 weeks, there is a multiple macular rash, as you can see from this picture. No treatment is required. It is not caused by fungus. It is not like a fungal infection. Okay, like tinea versicolor, that may also, it is potassium hydroxide will show spaghetti and meatball. Okay, and there is fungal infection, but tinea, this is not tinea versicolor. Okay, potassium hydroxide test will be negative. No treatment is required. So that's pityriasis rosea. Next we have rosacea. This is rosacea. So rosacea means rosy hue, flushing of the skin with telangiectasia on the cheek, nose, chin, and it is precipitated by hot and cold fluids, change in temperature, heat, and this flushing. So there is basically flushing of the skin. In carcinoid syndrome, there is flushing of the skin, but that is for few seconds only. In scombroid poisoning also there is flushing of the skin, but that is for few seconds only. In case of rosacea, the flushing it is for longer duration. This is characteristic. And it can, in severe condition, there can be, this is severe case of rosacea. There you can see papules, pustules, okay? You can see the pus. Treatment is topical metronidazole. Topical metronidazole, and there can be ocular lesions also, like conjunctivitis can occur. This is also important point. Conjunctivitis, episcleritis, scleritis, blepharitis, and chalazion. So conjunctivitis, episcleritis, blepharitis, and chalazion. These lesions can occur. So you can be asked question like this rosacea. It is associated with what are the diseases which are what are the things which are associated with rosacea? These are the uh, lesions. Okay. Okay. So there is characteristic feature is involvement of the nasolabial fold, as you can see. In case of SLE, there is sparing of this nasolabial fold. So this is SLE. So there is sparing of the nasolabial fold. Okay. Here there is involvement of the nasolabial fold. In seborrheic, so SL is the only condition in which there is sparing of the nasolabial fold because there is butterfly-like lesion. In seborrheic dermatitis and also in case of rosacea, there is involvement of the nasolabial fold. This is how, this is the differential diagnosis. This is how you can differentiate. Okay. Now, uncontrolled rosacea can lead to rhinophyma, in which there is overgrowth of the nasal skin. So this is rhinophyma, as you can see. This is also, this occurs because of uncontrolled rosacea. Okay, clear? Any questions? Rhinophyma, it is because of uncontrolled rosacea. There is overgrowth of the nasal skin. Skin mainly occurs in older patients. So this is rhinophyma. Okay, so that's for rosacea. Any questions? Treatment is topical metronidazole. Okay, and there are skin lesions, chalazion, blepharitis, which is involvement of the margins, eyelids, eyelid margins, scleritis, episcleritis, conjunctivitis. Okay. Okay. Next is pemphigus, pemphigoid. These are simple. So basically, pemphigus, it is flaccid ulcers, flaccid blisters. Uh, so this is pemphigus. You can see the blisters. They are broken down. They are flaccid. Okay, because and they are present in the oral mucosa, and on biopsy there are, because it is an autoimmune disease. Pemphigus, pemphigoid, it is an autoimmune disease. So there is formation of IgG deposits which act against the desmoglein intercellular addition, which is desmoglein. Okay, so that's why painful, this is, we have painful flaccid blisters. Okay, so these blisters break off very easily, and there is involvement of the oral mucosa. And on immunofluorescence, diagnostic test of choice will be biopsy with immunofluorescence, which will show IgG deposits intercellularly. Okay, so this is characteristic. You can see IgG deposits intercellularly. Okay, so this is characteristic. Okay, you can see this picture. This picture may not come in the exam, but basically you will have this kind of picture, a flaccid blister. So that is pemphigus. Okay, treatment is steroids, topical steroids. Diagnostic test is, I told, immunofluorescence. Okay, so occur in the oral mucosa. This is characteristic of pemphigus. Pemphigoid do not occur in older oral mucosa, mainly occur in older patients. Okay, So this is pemphigoid, as you can see. So these are painful blisters, but they are tense blisters, as you can see, and they occur mainly in older patients. Okay, so pemphigoid mainly occur in older patients. Okay, and do not involve the oral mucosa. No oral mucosa. Okay. In case of bullous impetigo, there won't be such tense blisters, and there won't be any history of involvement of the older patients. Okay. Such tense blisters, they are seen only in case of pemphigoid. Okay. So immunofluorescence show IgG and C3 deposits in the dermal epidermal junction. Treatment is against steroids. So this, as you can see, this is the epidermis dermis. Okay. So you can see IgG deposits at the dermis epidermal junction. So that's why a thick a whole layer is involved. In case of pemphigus, there was a very thin layer that was just epithelial layer was involved. That's why very flaccid blisters occurring in the oral mucosa. Here we have tense blisters. Okay, because there is a very whole of the epidermis is involved. Okay, as you can see, clear. So this is uh, pemphigoid. Okay, clear. Any questions?